Hello, I'm Matt Hall. Our goal in this presentation today is to introduce two new concepts, three new tools, and two new research results. So let's go ahead and get started. The first concept we'd like to explain may not be completely new to you, but it never hurts to have a little reminder. The concept is this: the average range has a different meaning in clinical work compared to research contexts. Now, I am assuming that all of you are familiar with the clinical definition, but if you are looking at the research literature and applying the clinical definition to research studies, it is easy to misinterpret those results. Let me explain. So it is appropriate to use the clinical definition if you're working with one individual, trying to support their development and meet their individualized needs. But research works a little bit differently. First of all, of course, we tend to be studying many people at the same time. We call that the sample. And then this sample typically represents a larger group called the population. And in most cases, the goal of research is to understand what's really going on in this population. So now how does that impact the definition of the average range? Let me show you. Suppose you're evaluating a client and they have a standard score on some assessment of 95. In general, that's pretty good. Maybe this person still needs some support for a few particular areas, but in general, we can feel pretty good about that. Now, suppose you are reading a research study and they find that the average score in their sample is a 95. Is the interpretation the same? No, it is not. And that's because this means that in the population, that whole distribution is shifted down a little bit, which means that the red area here increases in size. Notice that in a healthy population, you will have a maximum of 16% of that population in the red area. And compare that against this shifted distribution where now 25% of the population is there. That's a 59% increase in risk for just a very small shift downward. So now look at what happens when the population distribution shifts even farther down. Now let's suppose that your client has a score of 90, and the interpretation there is still pretty good. This is within normal limits, or within the average range, right? But notice in this research study, now this mean of the sample is a 90, and notice that population distribution has shifted to the point where 37% of the population is in the red area. That's a 133% increase in risk. Let me show you one more. Now the client's test score is an 85, which is right on the border, but technically still within the average range. And here we have a research study where the group, or the average, the sample mean, is an 85. This implies that half of the population will fall into the red area. So this is more than 3 times the risk of typical development, or a 216% increase in risk. Now, maybe earlier this spring, you read a summary from the Informed SLP, summarizing the results of the Australian LOCHI study, LOCHI. And the result in that study was that spoken language outcomes for deaf and hard of hearing children in Australia looked like this distribution over here. And I have to tell you, it's not just Australia. Most of our large-scale research studies here in the US show a similar pattern. I think that part of the challenge with this kind of thinking is that it's really not easy or intuitive, particularly when we're talking about standard scales. They just work a little bit strangely. For example, have a look at this graph. On the x-axis, we have the sample mean, and then on the y-axis, we have the percent of the population that would be in that red area for different values of the sample mean. The blue line that's shown here indicates the true value based on simple math. But we were curious to know how real people think about these kinds of scales. What are their intuitions? Do they match or mismatch reality? Now, this study is not specific to deaf and hard of hearing children. This would apply to any use of standard scales. So we ran an experiment where we asked participants to guess, for each value on the x-axis, what % of cases would be in that red area. And here are their responses. What this means, notice the shaded area. This is people underestimating what proportion of the population is going to be in the clinically concerning range, which means they are underestimating the amount of clinically significant risk. Unfortunately, this is not our only problem. There's another but related issue, which is how should we or can we communicate this information to families with deaf and hard of hearing children? Communicating about risk is always a challenge, regardless of what the data look like. I'm going to use this situation as my example because this seems to be pretty close to the situation for deaf and hard of hearing children in Australia and in the US. So if our goal is to explain this situation to hearing families, well, we have lots of options. There are many different ways that we could describe this distribution. For example, just go ahead and read options A, B, and C here. So do you notice how option A is positively framed? Option C has a strong negative framing, and option B is somewhere in between. But it's important to notice that all three of them are equally true. And so the question is, if we are trying to communicate this situation to families, which of these statements is going to best help them understand the situation? And we don't know, so we ran an experiment. There were two things that we wanted to know. First, what kinds of messages are actually being sent to hearing families with deaf children? And then two, how do people typically interpret those kinds of messages? To answer the first question, we reached out to state directors of EDI programs and asked them to send us the informational materials or packets, whatever they typically send to families, be it papers, websites, whatever. We gathered those materials and reviewed them, looking for any statements about language outcomes. We found a total of 487 statements. And then in the next set, we looked through those 487 statements, looking specifically for statements that compared outcomes in deaf and hard of hearing children who followed recommended procedures, compared with typically developing children. The first result is that only 6 statements met our inclusion criteria. In other words, only 6 statements compared deaf children who followed these recommended steps against typical development. Which means that most of the time, hearing families are simply not receiving information about that comparison. Now, we did find lots of statements comparing what happens when deaf and hard of hearing children don't follow recommendations relative to typical development. And we also saw a good number of statements comparing what happens when deaf and hard of hearing children don't follow recommended procedures compared with when they do. There were plenty of those as well. But there were very few, in fact, only 6 statements comparing what happens when deaf and hard of hearing children do follow recommendations against typical development. I'll show you those 6 statements. If you'd like to read them for yourself, I suggest that you pause the video and have a look. Here's number 1. Number 2. Number 3. Number 4. Number 5. And number 6. So now that we've identified those 6 statements, now we're ready to answer that second research question. So how do people actually interpret this kind of information? So we ran another experiment where we showed these statements to undergraduate students, and we asked them to assume that these statements are true. How many children do you think will have scores within or above the average range? Now, because our students may have preconceived beliefs about deaf and hard of hearing children specifically, we used a different cover story, but we made sure to keep the structure of these statements the same. So let me explain how this graph works. On the y-axis, this is showing how many people our participants believe will fall within or above the average range. The dotted line here at 50 is here because, as you saw recently, 50% is about the actual value that we're seeing in Australia and the US. And so this means that if participants' beliefs are close to this line at 50, then in fact those statements are communicating effectively. On the other hand, if their beliefs are below the line, that means these statements are framed in overly negative ways. And if the beliefs are above the line, this suggests that those statements are framed in overly positive or overly optimistic ways. So here are the results. So it would seem, unfortunately, that these statements are leading people to believe that language outcomes are better than the research literature suggests. So I hope now you understand why I say that the average range has a different meaning in clinical practice than in research. So the next time you're reading a research study that says that the sample mean was within the normal range, I hope that you'll remember this presentation and pause to take a moment to think about the population, and remember that when the distribution is shifted even a little bit, it can still mean a significant increase in that red area. So now I'd like to introduce the second new concept, and this is called a language access profile. I sign it this way. So language access profiles are a better way of describing deaf and hard of hearing children's experience with language input during the birth to 3 years. Let me explain. First thing we need to do is differentiate language exposure from language access. By language exposure, I mean whatever communicative signals we are sending to someone. And by language access, I mean whatever communicative signals that person is receiving. Now, for most hearing children, exposure and access are largely the same. But unfortunately for deaf and hard of hearing children, they are often not the same. For example, if someone is using spoken language, but the deaf or hard of hearing child can't hear it, or hears only a small amount of it, that may be language exposure, but access would be reduced. The same is true if someone is using visual communication with a child who has limited vision or who is not looking. And once again, you maybe could consider that exposure, but it's certainly not access. The key point is that language acquisition requires language access. It really depends on language access. And the problem is that so far, we have had no way of describing or documenting deaf children's cumulative experience with language access. We haven't had these tools in clinical contexts or research contexts. Now, maybe you do collect language history information. That's great, but most assessments of language history are really about language exposure and don't consider access. Largely because most forms for collecting language histories are not designed for deaf and hard of hearing children. Now, maybe you supplement that by adding information about the child's communication mode, but that is definitely not enough, and I'll say more about that later. For now, let's look at how we visualize language access profiles. So let's take a look at this first axis, going straight up. This represents limited access. This includes time that has passed, for example, if a child has not yet had access to language input until a certain age. That would be added to this category. And even after language access begins, we know that it's not complete, it's not full access, there is a gradient. And so this axis helps us to estimate the degree of access that the child has or does not have to any given type of language input. Around the rest of the image here are the other input categories. So we have spoken English. By this we mean there's no sign or visual support, and that's reflecting what the child can hear. The next axis is about American Sign Language as a language in its own right. The next axis is for sign-supported speech, which often borrows signs from ASL but is typically expressed in English order, and is really just another way of expressing English that typically features primarily content words. Down here we have cued speech, which helps people to see the difference between speech sounds that are visually similar. Here we have manually coded English, which is another way of expressing English on the hands, but this category really follows English morphosyntax very strictly. For example, the baby is sleeping. We have another category for other spoken languages, such as Spanish, or Hindi, or any number of others. And there's a category for other or unknown, because sometimes deaf and hard of hearing children have complex experiences that are hard to capture. And so we have this category to reflect those idiosyncratic experiences. Overall, this shows the child's full language access profile, focusing on the period from birth to age 3. So I'm just going to show you a few different children's profiles and what they look like. So they may look like this. This would indicate that this child has had very limited access to any form of input during the birth to 3 period. Maybe this child was late identified, maybe they were internationally adopted, who knows. You'll notice that there is a little bit of auditory access to spoken English, but just a tiny amount, about 5% is the estimate, something very small. We have about 10% estimate for ASL, but really most of their experience seems to fall into the limited access category. Here we have a very different child with a different experience. This child has a lot of auditory access to spoken English. It's estimated here about 90%, or maybe it's 85%. And there is only about 10% of this child's experience consisting of limited access, and here we also have a little bit of sign-supported speech. Here is different again. In this case, we have about 20% limited access, 30% auditory access to spoken English, and in this case, most of the child's input is coming from sign-supported speech. This child has lots of access to ASL. This is about 80% ASL, with just a little bit of sign-supported speech, and really no auditory access to spoken English, and no limited access either. There is a tiny bit of manually coded English, just a little. And here once again we have another child who has lots of ASL, although a little bit less, more like 60%. Here we do have more auditory access to spoken English, some sign-supported speech. Here there's no manually coded English, and just a little bit of limited access. So now I'm going to show you all of them on the same plot. And what I hope you can see is that each of these 5 children has had a very different experience with language access. But the other thing I'd like you to notice is that if we relied on communication mode to describe these children's experiences, all 5 of them would be considered to have the same communication mode. All 5 of these children would typically be considered signers, or maybe in a total communication category. And so that kind of approach really ignores a lot of important information about the different experiences that these children have had. I'd like to show you another quick example to make a point. If we were to use communication mode, then these two children would also be considered to have the same experience. Both of these children would be considered oral or following a listening and spoken language LSL approach. Because for both of them, there is no kind of signing. All of the family is focusing exclusively on listening and spoken language. But if you actually look at their experience with language access, these two children are very different. This one child has lots of auditory access, and this child has very little auditory access to spoken language. So their real-life experience is very different, but communication mode would say that they are the same. And similarly, in this other example, let's look at two quote-unquote signing children. Once again, you can see that there is a little bit, about 5% of this child's input has come from sign-supported speech, and that is often enough to have that child labeled as a signer. Similarly, here we see a child with about 10% of their input coming from ASL, and again, traditionally, that would get this person classified as a signing child. And so communication mode categories would say that these two children's experience is the same. And so once again, if we are relying on communication mode, we would categorize the top two children into one category with each other and the bottom two children into a different category with each other. And my question is, does that make sense? I don't think so. I think it would make a lot more sense to categorize the two children on the left together and the two children on the right together. And so that's how language access profiles work. So now I'd like to transition to the second part of this presentation, introducing 3 new tools. They are all available now, but please understand that they are all still in beta testing. The first 2 have to do with the goal of measuring language access profiles, and the third one is designed as a measure of ASL vocabulary development. So as I was recently introducing the concept of language access profiles, maybe you were thinking that, okay, this sounds like a nice idea, but how do you get those numbers? Where do they come from? The answer is that you can use either of these tools. So I will briefly explain them and compare them. Today I'm really not going to be discussing how to apply the results in clinical practice, but if you're curious about that, I would encourage you to look for another presentation by Dr. Stephanie DeAnda, my collaborator and colleague. So our approach has these 2 parts. A few years ago, Dr. DeAnda developed the language exposure assessment tool, which was designed for hearing children who are acquiring multiple languages. And for the past little while, we have been collaborating to modify that tool for use with deaf and hard of hearing populations. And we are now calling that the D-LEAT. At the same time, we have also been developing a second tool that's a new instrument that is called the Language Access Profile Tool, or LAPT. So first I'll explain the features that these tools have in common, and then I'll identify a few places where they differ. First, both of them are in fact designed to measure language access profiles in deaf and hard of hearing children. And they both do that through a technology-supported interview protocol with the child's parents or other caregivers. They both have strong reliability. It does not matter who delivers the interview, and if you interview the parents again after a little while, you will get the same results. They also show strong validity in terms of face validity, content validity, convergent and divergent validity. You can use these via telepractice. In fact, they were actually designed for telepractice. You can use these tools with children whose current age is anywhere from birth to age 12 years old, but the reporting period that the interview focuses on is the period from birth to age 3. And last, both of these tools are available for free. So now let me discuss where some of the differences are. First, the D-LEAT is built on an already validated task, the original LEAT that we modified, whereas the LAPT is a tool that we have created. The D-LEAT provides a more rich source of information. The LAPT is a bit more superficial. But at the same time, the D-LEAT is a little bit more complex to administer, and the LAPT is a little bit easier. Likewise, the administration time that's required for the D-LEAT is a little bit longer, about 30 to 60 minutes, whereas for the LAPT, it's closer to 15 to 30 minutes. Now, just as I said before, you can use either tool with children who are anywhere from birth to 12 years old. You can, but our recommendation, based on our experience, is that we found that the D-LEAT works best with children who are still in that birth to 3 window, whereas for older children, age 3 and up, the LAPT may work a little bit better. As far as connectivity, the D-LEAT does not require an internet connection during the interview, whereas the LAPT definitely does. And regarding the software platform, the D-LEAT is spreadsheet-based, whereas the LAPT is web-based. In terms of the graphical output at the end of the interview, it is not yet available in the D-LEAT. We are planning to add it soon. It is already built into the LAPT. So here is the basic overview of the D-LEAT procedure. The first thing you do is list the child's primary communication partners, and then figure out what kind of communication they typically use, and document their approximate proficiency level, just at a low, medium, or high scale. Next, you figure out when did the child first have access to language. Maybe it's birth, but sometimes for deaf and hard of hearing children, they don't have access to language until something happens. For example, amplification or implantation, or when the family begins to use a form of visual communication. Whatever their first language access was, document the age at which that happened. It's quite important to document if there was a period of time when the child's experience consisted of entirely limited access. Then we move on to the real meat of the interview. For each communication partner, you figure out the schedule of interaction with the child. For example, at what age did it start? How many days per week? How many hours per day? And then during that time when these two interlocutors were together, about what % of the time was this person using different forms of communication? And then finally, how accessible were those different kinds of communication to the child? For example, suppose that grandma always uses spoken language with this child. The child's access to that spoken language may change over time. For example, prior to amplification, the child may have very little auditory access, but that may increase at amplification, and it may increase even more at implantation. And we'd like to capture those changes. Now, be aware that so far we are relying on parent report, just their intuitive estimate, and we know that those are not always reliable estimates, so we do recommend that you check with the child's audiologist to see if you might want to adjust those parental estimates. So that is the basic procedure for the D-LEAT. Note that this is a time-based estimate. The numbers are not just being made up, it's actually following their real-life schedule, and that helps us believe that we can trust these results. We have noticed that the D-LEAT tends to be best when working with younger children that you're going to be seeing again and again. For example, children that you're serving through their IFSP. We recommend readministration every 6 months. Part of the reason for that is that this can help us identify goals and track progress. Now, we are used to thinking about setting goals for language outcomes, but if we want to see those outcomes, we have to also pay attention to the input. And so we can establish goals for language input and track them over time. The other important part of this information is that it can show us where limited access is still happening. Whatever that situation is an important target for intervention. So now let me show you the basic steps for administering the LAPT. Recall that this is run online through a secure HIPAA-compliant web portal. The first screen asks you to document some metadata, and then there's a screen that's designed to help parents understand the difference between language exposure and language access, just like I explained to you a few moments ago, using the same image. And families tend to be able to understand that. Next, there is a warm-up screen, and there are 3 goals for this screen. First is to help the family understand those different types of communication, those different input categories. Sometimes families need a little bit of support understanding, for example, what's the difference between ASL and sign-supported speech? And so this helps you describe and show some examples. The second goal of the warm-up period is to help eliminate input categories that are just not involved in the child's life. You can set those aside, which saves some time. And then the third goal of the warm-up is just to get a very rough general idea of what the child's experience has been like. That's going to help you during the meat of the interview. So when the warm-up period is over, then you move on to the real core of the interview. And it begins by just focusing on the first year of life, from birth to 12 months. You ask the parents, okay, think about your child's experience during that first year of life. Let's call that 100%. Now, how should we divide that 100% across these different kinds of input categories? And the system forces them to use bins of 10% each, 10, 20, 30, 40%, to create the best fit that matches their intuition. When the first year is done, the system moves on to age 1 to age 2, and you do the same process. Again, just figuring out what the second year is like, and then once again, do the same for age 2 to 3. And then the system automatically averages those 3 yearly estimates. When that third year is finished, there's a section for demographic questions that are optional. You can use them or not. If you feel that they will be helpful for you or provide good opportunities for informational counseling, you may decide to use them, or you can skip them. It's up to you. And then at the end, there's a screen that shows the child's language access profile. And once again, that's an opportunity to discuss that with the parents, maybe a counseling opportunity, etc. So those are the basic steps for the LAPT. Let me just make a few more points. First, I didn't mention before that the LAPT actually does include some descriptions and a few video examples that are designed to help families understand the different kinds of what different kinds of communication look like. I did mention this point before. We ask families to make their estimates in bins of 10% each. So this means it's not exactly a time-based estimate, it's more intuitive, but it's actually a little bit more similar to how traditional spoken language background questions work. Often bilinguals will be asked to estimate, what percent is English, what percent is Spanish, 80-20, for example. So it may be more familiar to families, and we have also found through our research that when you use the percent-based method and the time-based method, they actually strongly agree with one another. When you give them both to the same family, you will get the same answer. However, the percent-based approach does save some time. It's a little bit simpler. And so we prefer to use that when you have an older client and you have to look back a longer amount of time. It just seems to be a little bit of an easier way to collect that information. So why do we want the early information? Well, we know that language input influences language proficiency. And so if you have a language assessment result, but you don't know what happened in that child's life, it's hard to interpret that result appropriately. And so gaining more information about this prior context, especially during this critical period from birth to 3, which we know is an especially valuable time for language acquisition, if you don't know what happened during that time period, even if you're working with a client who is now older, you're still missing critical information. And so this is a way of gathering that. And likewise, if you have an assessment result and you're trying to make a diagnostic decision or an intervention plan, this profile provides more information that can inform that decision. So now I have described these first 2 tools. If you are interested or curious about learning how to use them, you can sign up for training. You can take a picture of this QR code. The training is available online. It is free, and it is self-paced. So now, to explain the third tool, I will hand things off to Dr. Naomi Caselli.
Hi, my name is Naomi Caselli, and I will be sharing a little bit about the third tool we've developed, which is called the ASL-CDI. The ASL-CDI is an ASL adaptation of the MacArthur-Bates Communicative Development Inventory. It was developed by myself in collaboration with Amy Lieberman and Jenny Pyers. It's now available. You can check it out at aslcdi.org. The ASL-CDI is a parent checklist where parents report on their children's language abilities. The first part focuses on vocabulary, and the second part focuses on early communication. We've collected normative data from 120 deaf children who have deaf parents. These are all children who are between the ages of 8 months and 5 years old. We've also collected some additional validation data on a set of 40 children who are all deaf, some of whom have deaf parents and some of whom have hearing parents. And I'll talk more about that validation study in a minute. Here's what the test looks like. So I'm focusing now on vocabulary data. What you can see on the y-axis is the number of items the child knows, so a higher value is a larger vocabulary size, and on the x-axis you can see age. The growth curves indicate the percentile, so the 90th percentile is marked in gray, the 10th percentile is in that teal color, and that shows you what the age milestones are for vocabulary size at each age. On the left you can see expressive vocabulary, and on the right you can see receptive vocabulary. We did a number of things to validate the ASL-CDI to confirm its reliability and validity. I won't explain all of that in detail, but I'll tell you a little bit about one of the steps that we took. With that subset of 40 children, we wanted to make sure that parents could reliably report on their child's vocabulary and communication behaviors. So to confirm that, we tested some children either in the lab or we went to them and looked at their receptive and expressive vocabularies in an in-person task. The first was a picture naming task where we showed a picture, like a picture of the bird here, and we asked the child to tell us what the sign is that corresponded. So we expected the child to sign bird. And then their receptive vocabulary was examined using a picture matching task where we produced a sign, like the sign for a tree, and then the child had to select which picture matched from an array of 4. We had 20 items on each of these 2 tasks. These were all items that showed up on the CDI as well, and we compared what children did in the lab to what we saw in the parent ASL CDI, and we see high correspondence between what parents can report and what we saw in the lab. This is true both for hearing and deaf parents. And that helps us feel confident that parents can complete checklists such as these. There are a couple of advantages of the ASL CDI. It can be administered online, which is nice. Obviously, we didn't predict that COVID would happen, but we're finding that some tests can't be administered remotely, and this one happens to be able to be administered remotely. It is also possible to administer the ASL CDI even if the provider does not know sign language. Parents can go into on the website to complete the assessment. They also get a report summarizing the child's results. They can share that result with a provider like a school or earlier intervention specialist, a teacher, or an ASL model, and the providers can then see the results of all the children on their caseload. It's available now for free. Go ahead and check it out at aslcdi.org.
So we are now in part 3 of the presentation, the new data. We just have 2 more tidbits of information we'd like to share with you. Both of them answer the same question. What happens when hearing families start to learn and use ASL before the child turns 6 months old? The first answer is about language input, and the second answer is about vocabulary outcomes. Now, in our previous study, we interviewed over 100 families from across the country with deaf and hard of hearing children. And in this study, we wanted to focus on the subset of those families where the parents were hearing and the deaf child had at least some access to ASL before age 3. And we found a total of 30 families that met those 2 criteria. So now let's take a look at those 30 families, divided based on those who started using ASL before their child was 6 months old versus after. There are 24 families that started before 6 months, and here the y-axis is showing by age 3 what % of the child's cumulative input has consisted of ASL as a function of whether the family started using ASL before or after 6 months. Here's the result. If you'll notice, families who started before 6 months had a large range of input. Now, half of these children had a cumulative % ASL that was 15% or less. And so we might not expect to see strong ASL development in those kids. But the other half of this group had ranged from 15 all the way up to 66% of their input in ASL. And so maybe we would expect to see some of their ASL skills really developing strongly. In contrast, when the age of ASL onset was after 6 months old, the cumulative amount of ASL input was a maximum of 15%. Now, I'd like to clarify that we are not saying that you couldn't have more than 15% input in ASL even if you start after 6 months. We're just saying that in our data, this is what we saw. Now, this is important because we've been hearing a lot lately about linguistic quality. It seems that many people believe that deaf and hard of hearing children can't learn ASL from hearing parents because the parents themselves are not proficient signers and therefore can't provide high quality linguistic input to their children. But I'd like to emphasize 2 points. First is that belief that I've just described is an assumption that research literature has not yet documented, because most existing research studies have not paid attention to or measured ASL outcomes, and so we don't actually know what those ASL outcomes look like. It is definitely important to find out, but until we have those data, it's better not to assume. The second point is that low linguistic quality is not the only concern. Recall, as our data show, it seems that even when hearing families want to include signing in their child's input, they tend to provide a low amount of quantity. And so limited quantity still makes language learning difficult, even if all of that input were high quality. And vice versa, maybe deaf and hard of hearing children can learn from input of low linguistic quality if there is enough in terms of quantity. This study cannot distinguish those possibilities because we did not directly measure ASL outcomes. But my colleague, Dr. Naomi Caselli, ran a separate study, and that provides an important first step toward differentiating the impact of linguistic quality and linguistic quantity. I'll let her explain.
The second new result addresses the question, what happens when hearing families begin to use ASL with their child before the child is 6 months old? How does that affect their vocabulary? We focus on vocabulary for a few reasons. First, it's a critical component of language development. It's also an early emerging linguistic competence, so that makes it a really good candidate for early identification of a language delay. It's also a robust predictor, typically, of later language development, like syntax or pragmatics. So by measuring vocabulary early, we can get a sense of a child's prospective language acquisition. The reason we undertook this study is in part because one idea out in the field is that hearing parents may lack the proficiency in ASL to adequately support their children in developing healthy ASL skills. And some people out there assume that parents who are hearing and learning ASL alongside their children can't do so. So we wanted to take that as an empirical question and asked and conducted the following study. The study included 78 deaf children who had hearing parents. The criteria were that the child had to be deaf, learning ASL, younger than 6, and have no additional language-related diagnoses, blindness or autism, etc. And I should say that we did collect data on children with additional diagnoses, but didn't include them in the analyses that I'll show you here. We divided these children into 2 groups, those who began learning ASL between 0 to 6 months and those who began learning after 6 months. So these late learning children are still relatively early in the grand scheme of things compared to the existing literature. They're all exposed to ASL between 6 and 36 months. We compared these 2 groups of deaf children who had hearing parents with our normative data set that I talked about earlier. The results are here. On the left, the 2 panels you see there are from our reference sample or normative sample that I shared with you earlier. That's exactly the same data that I showed you before. In the middle, and these children are the ones who have deaf parents who are learning sign language from their parents at home and have kind of an ideal language learning environment. In the middle, you can see the children who have deaf parents or who have hearing parents but were exposed to ASL before 6 months old. And on the right, those who have hearing parents and were exposed to ASL after 6 months, so between 6 and 36 months. The top graphs show expressive vocabulary and the bottom 3 graphs show receptive vocabulary. In all of these graphs, you can see vocabulary size on the y-axis. That's the percentage of signs the child knows, and then age or chronological age or language age on the x-axis. The dark gray, the light gray dots are the chronological age. We felt that it was important to be able to see if a child, for example, is 4 but only started signing a couple of months ago. We want to know not only how many signs they know for their chronological age, but how many signs they know for the amount of time that they've been learning ASL. So we took their chronological age and subtracted out the age at which they began learning ASL to calculate the language age. The results, additionally, the growth curves that you see here, the red, yellow, and blue lines, show the average range that you'd expect based on the normative sample. So in all of these graphs, the lines represent, those growth curves represent the normative sample growth curves. And that allows us to compare how these children who have hearing parents are doing with respect to what you would expect given ideal language, sign language input and language learning environment. What we can see is that the children who are exposed before 6 months old, all of those dots, so all of the children's vocabulary scores look a whole lot like the normative sample. Really, the distribution is statistically no different from the normative sample. So, and I have to say, I was surprised about this result when we first saw it. I thought that yes, early exposure might be important, but I thought that there would be some degree of variability, parents who might not be motivated or families who don't sign very much at home. You might see vocabulary delays, and so you might see a downward shift where some of these kids aren't in the average range. And yet what we see is that the distribution of these children who have hearing parents and learn sign language before 6 months old are virtually indistinguishable from the normative data. There are a couple of outliers, but by and large, the distribution is completely overlapping. On the right, you can see the children who are exposed after 6 months old. And you see that there is, based on their chronological age, some delay in their vocabulary acquisition. Interestingly, when we look at their language age, we see kind of the opposite pattern where some of these kids are actually doing better than you'd expect based on the reference sample. So they're learning more words earlier than you'd expect of deaf children who have deaf parents. And that makes sense, right? If you're 4 years old, you've been signing for 3 months, you might have a larger vocabulary than a 3-month-old infant. So to summarize, despite having hearing parents and parents who are typically learning ASL alongside their children, children who are exposed to ASL before 6 months old seem to consistently have native-like vocabulary acquisition, at least in this data set. We also found that children who are exposed a bit later made rapid gains, which is similar to what we see in adolescence. Kids appear to be able to catch up in their vocabulary skills. The success that we see here in developing age-appropriate ASL vocabularies is in stark contrast to the relatively small spoken English vocabulary sizes that we see reported again and again in the literature on deaf and hard of hearing children. What does this mean for early language acquisition? What it means is that these children who are exposed to ASL early appear to be protected from the effects of language deprivation, at least in terms of vocabulary. There are lots of open questions that remain. Clearly, vocabulary is just one part of language acquisition. There's much more that we need to look at. to see how these children do with syntax, pragmatics, other aspects of development that depend on early language input. So we need to investigate more of those types of factors than just vocabulary. But it is nice evidence that and reassuring data that these children who have early exposure to ASL seem to be able to develop healthy ASL vocabularies. We still don't know what the necessary ingredients are for ensuring age-expected vocabulary acquisition. Is it the case that there's some magic about being exposed to ASL by 6 months, or is it that there's something unique about these families who begin signing before 6 months that is really what the driving factor here? For example, these families have high cumulative ASL input, and that may be really what's driving the effect here. We might also think that parent signing skills have something to do with it. It may be that the families who can begin to sign early have access to resources or already took some ASL classes or other things that may set these children up for success. So we need to do more research to determine what exactly about these kids' language experiences are leading to success. But nevertheless, it suggests that children can develop strong ASL skills when exposed to ASL early.
So finally, we have now introduced 2 new concepts, 3 new tools, and 2 new research results. I hope that all this information is helpful to you. If you'd like to ask us any questions, please do go ahead and get in touch. Thank you so much.